You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract. Hello, and welcome back to another episode of Beyond the Abstract. Today, we're sitting down with Dr. Pouya Azar to discuss his new article featured in the Journal of Addiction Medicine titled Transition to Extended-Release Buprenorphine Injectable Within 7 Days for Opioid Use Disorder Treatment, a Scoping Narrative. In our interview, Dr. Azar explains the potential benefits of transitioning patients with opioid use disorder from traditional to extended release or long-acting buprenorphine within 7 days or 24 hours, respectively. He also discusses some of the challenges clinicians may face when implementing rapid transition to injectable buprenorphine, as well as some of the future research he feels would be beneficial in answering some of the questions that emerged from his narrative review. Dr. Azar is a clinician-scientist in addiction psychiatry and pain medicine based in Vancouver, British Columbia, Canada. He serves as co-medical manager of the Complex Pain and Addiction Service at Vancouver Coastal Health, a consult service providing management of pain, mental health disorders, and substance use disorders across Vancouver General Hospital, the University of British Columbia Hospital, and GF Strong Rehabilitation Centre. He's also an assistant professor in the UBC Department of Psychiatry, research scientist co-lead of the Substance Use Disorder Clinical Research Unit at the BC Centre for Excellence in HIV and AIDS, and a physician at the Vancouver General Hospital Transitional Pain Clinic. His clinical and translational research focuses on developing novel opioid agonist treatment initiation and withdrawal management protocols, medical devices, digital health apps, and prevention programs to improve patient outcomes. Now let's get into today's chat with Dr. Pouya Azar. First of all, thanks for being here. We really do appreciate you sitting down and talking with us. It's great to have you. And I want to start all the way at the beginning and kind of find out why this field in particular. So tell me, doctor, what was it that led you to the field of addiction medicine?
Yeah, good question. I don't think I have a very inspiring story, to be honest. Now, I went to psychiatry because to me, it was that interface between medicine, neurobiology, and like philosophy, and art. And it was this, trying to understand how the mind works and the mysteries of the mind is just absolutely fascinating for me. I went into addiction medicine. I did my fellowship. This was back in 2013 when it started. And I did an addiction medicine fellowship, not an addiction psychiatry fellowship. So not that there's a huge distinction. Back then, I just enjoyed the pharmacology. Pharmacology has always been one of my loves. And the neurobiology of addiction. So it was an interest in that regard. I didn't have any huge altruistic motives to save the world at that time. What was interesting, though, was so this is 2013 Vancouver. I went in not particularly expecting to lose a lot of patients. And then I'll never forget my first interview. I was interviewing a 16-year-old kid, and he told me that he was smoking fentanyl. And then that blew my mind because I'd never heard that before. And at first I was like, using fentanyl, like fentanyl patches? I'd heard, some anecdotal stuff about people trying to extract fentanyl from patches. But he's like, no, we're smoking fentanyl. And then I was like, whoa, okay, like, if this is actually happening, and I was somewhat in this, and this was actually like early days of virtual care where he was at a treatment center sort of in a rural part of British Columbia, the province in which we live. And so I was seeing him through video conference. I was like, wow, like if this is actually happening, this could change things. And then very rapidly, the prevalence of fentanyl just went through the roof within that year. So I got to see the landscape, the pharmacology change dramatically within 1 year. And within that year, I lost count of how many patients I lost to overdose or fentanyl poisoning or whatever you want to call it. So then that perpetuated my love and desire to make change within addiction medicine, because we were in a place, and this is actually, and I hadn't prepared this, but it's actually very closely related. to this topic because we found ourselves in a void of evidence. More and more of the tools we had to treat our patients were becoming less and less effective. I remember in the good old days of heroin, somebody came into hospital, they were in withdrawal, oral morphine solution, 10 to 20 milligrams Q4H-PRN was adequate to meet their opioid requirements, keep them out of withdrawal, start methadone. Methadone doses back then, 50 to maximum 150 milligrams, and patients were comfortable. And that became less and less applicable. And we had to come up with new tools to treat our patients more effectively. And that's where our research program evolved. It was out of this clinical need. And at first, it was just me thinking about the pharmacology, the neurobiology, and seeing like, okay, is there another way we can induce people onto buprenorphine? These patients, their tolerances are super high. Withdrawal is horrible. They're not going to be able to sit through withdrawal to get our traditional inductions. Is there another way of doing it? So our research program evolved out of the need to come up with clinical tools to treat our patients today. It wasn't sort of like researchers thinking of clinical problems and then thinking of a clinical application for it. So as usual, I'm a little bit tangential. So we started talking about the reason I went to addiction medicine. Now we're talking about how our research evolved, but they're very intimately connected.
Yeah, well, that's a great transition. I want to ask you a little bit about your narrative review now. And let's start off with this. Tell me, what are the potential benefits of transitioning patients with opioid use disorder from traditional to extended release or long-acting buprenorphine within that 7-day or 24-hour period, respectively, of treatment?
Right. Well, here's the thing. So our patients are a very diverse group of individuals, right? They come from different circumstances. Many of them, and maybe the most visible population, are the ones who live under very difficult circumstances, have very high opioid tolerances. And with fentanyl, and to provide some pharmacological context for this discussion, most people still don't. When I mean people, I'm talking about addiction clinicians, may not fully appreciate the type of opioid tolerances that we're seeing in our patients who use fentanyl. Right? So I think we were the first group to quantify this because we came, out of our need to treat withdrawal more and more effectively, and from the time where morphine became less effective, then we went to hydromorphone, which is 4 to 5 times more potent, and went from oral to parenteral, and still it became, for a certain segment of this population, not very effective in terms of treating withdrawal, keeping them in hospital. We came up with a protocol to use intravenous fentanyl to treat withdrawal. Again, a little bit circumstantial, but you'll get to the point. I'll get to the point. So through this protocol, we were able to, using pharmacokinetics of fentanyl, come up with a way to titrate people onto IV fentanyl in a safe and effective way. I won't go into the details because that's not the point. The point is, though, through this protocol, we were able to quantify how much fentanyl was required to get somebody out of withdrawal and get them comfortable, right? And it was staggering. We were all blown away. So we're talking about typically, at minimum, 4,000 to 5,000 mics of IV push fentanyl to get somebody comfortable. Sometimes, and more typically, 8,000 to 10,000 mics of IV fentanyl. And for the most difficult to treat, we're hovering around 20,000 mics of intravenous fentanyl to get somebody out of withdrawal. Right? It's staggering. And to be very clear, and I think there's been some confusion around our protocols and research, by no means am I advocating to use intravenous fentanyl as a treatment for fentanyl addiction, right? There's a very specific application of this protocol in the most difficult to treat patients, just to treat withdrawal and keep them in hospital in order to be able to get them on to MOUD or meet their opioid requirements. And that's an interesting debate in of itself, and one that's actually caused us, just brought us into controversy where I never thought it would. I had applied to present at a particular conference, and somebody, and for a couple of years, everything was accepted, everything was fine. And then 1 year, all of my stuff was rejected. This conference. And then, so I knew somebody who was on the board, and I was like, yeah, give me some feedback. How may I adjust things? And they're like, you know what, like, I'm a big fan of your work. There was somebody on the committee who was very vocal. They saw you present at a different conference. They think you're too extreme, particularly with regards to your views on using fentanyl. So it was interesting that, like, it struck me at that point that, wow, like, this is controversial in a way that I never thought it would be. Now, back to the point of your original question, was the tolerances that we're seeing in our patients are staggering. So, which also means that the level of withdrawal, subjective and objective, is also staggering. So now this expectation, when you look at the standard induction protocol for buprenorphine, to wait for somebody to go into withdrawal before you give them the medication, may limit a number of people from receiving the medication, because many patients, from my experience, will leave hospital to use illicit or unregulated fentanyl prior to going into the amount of withdrawal we need them to be in to start them on buprenorphine, right? So in that sense, we're immediately going to lose a certain proportion of our patients. And then comparing a rapid induction, and we have various protocols that we're using and we've published on. When I say rapid, it's usually 24 hours or less to get somebody onto buprenorphine. And the most rapid one that we have now, which we've recently presented at, it was ASAM, is within minutes. But yeah, and we can talk about that specific protocol if you like as well. However, when you think of the difference of, low dose induction or microdosing, whatever it's called, getting people onto buprenorphine over 7 days versus 24 hours, during that 7 days where you're titrating up the dose, you're not meeting the dose of buprenorphine, starting at low doses, gradually building it up. You're not meeting their opioid requirements. So they are going to be in some level of withdrawal, and that's what we want to avoid. So if you're doing it in an outpatient setting, very analogous to methadone, they're still going to use fentanyl until you get them to an adequate dose, right? So during the 7 days that you're low dose inducing them, if you're doing it in an outpatient setting, they're going home, and if you're not giving them full agonists, they're using fentanyl, which is expected. Very similarly, when you start somebody on methadone, you start at a low dose, you gradually build up the dose. During that dose titration, they're still going to be using fentanyl, right? And the whole point is you titrate until you clinically meet their opioid requirements and they no longer have the need to use fentanyl. But during that time, they're still in the midst of their addiction, in the midst of the chaos, and very often they'll fall off of treatment, they'll miss doses, and they remain at risk of overdose.
You're touching on it a little bit, but are these some of the challenges? Talk to me about the challenges that clinicians that are implementing this rapid transition to injectable buprenorphine, what might they come up against?
Well, yeah, so that's exactly it. So this was the need to come up with much more rapid induction protocols, right? So now the beauty of the depot preparation of buprenorphine is once it's in, now you're protected, right? So if you're using the monthly injectable formulation, once it's in, you're protected for a month. The 7 day, you're protected for 7 days. But the goal in my mind is to get people on in as much comfort and as quickly as possible to prevent that the time in which they will continue to use full agonist or unregulated fentanyl. And the reason we've had to come up with these induction protocols and the challenges that many clinicians face is ultimately precipitated withdrawal, right? So, and as you know, precipitated withdrawal is a sudden onset of severe withdrawal that's very difficult to treat, which can happen if somebody is not in withdrawal, is highly opioid tolerant, and you give them a treatment dose of buprenorphine right away. Anything above 2 milligrams, they'll go into severe withdrawal. And there's a sense that precipitated withdrawal, patients who use fentanyl are at much higher risk of precipitated withdrawal than those who might use less potent, less lipophilic opioids, such as heroin or morphine. And there's some neurobiological explanations for that, which we don't necessarily need to get into. So the challenge is precipitated withdrawal, and the solution has been to look at the neurobiology and the pharmacology and to come up with ways to get people onto buprenorphine quickly without the risk of precipitated withdrawal.
So I want to ask you too, and you've sort of been talking about this a little bit, but can you go in a little depth about describing the differences between extended release buprenorphine and long-acting buprenorphine, and whether one type might be more beneficial for certain patient populations versus others? So,
pros and cons. In my mind, if a patient has tolerated buprenorphine in the past, so from a pharmacokinetic perspective, there isn't a huge difference in terms of Tmax, time to max serum level, between the two formulations. But the duration of action is different, obviously. So if somebody's tolerated buprenorphine in the past, they know what they're getting themselves into, they want this treatment, to me, it's a no-brainer to give them a 28-day or 1-month formulation, because it reduces the number of visits they're going to require. It's going to protect them for a prolonged period of time, etc. Now, there's some arguments for the 7-day formulation. You might say, well, they may not necessarily know what they're getting themselves into. They haven't had much experience with buprenorphine in the past. Let's try 7 days. If they like it, then you can do the 28-day formulation. For some patients, it just might be more tenable to do a 7-day because they know it's more time limited as opposed to committing for a whole month to a particular treatment. Some people might argue that it might be beneficial for a patient to need to come back once a week to maintain that continuity of care, to be checked on, etc. So there's pros and cons. In British Columbia, where I practice, in Canada, we don't have the 7-day formulation, so we only have the 20-day formulation. And in my mind, my main goal is to keep patients alive and prevent death from fentanyl. And if I can protect a patient for 28 days in a row, that's all things equal, that would be the one, from my clinical perspective, what I would choose for patients.
I wonder too, are there concerns about how well rapid transitions to injectable buprenorphine might be tolerated by patients using synthetic opioids like fentanyl compared to other opioids? I know you talked a little bit about tolerances and things like that, but what other concerns kind of present themselves here?
So that's interesting. And there's this notion, exactly like you said, that then there's a much higher risk of precipitated withdrawal. Inductions are much more difficult in patients who use synthetic opioids. So highly potent opioids, high receptor affinity, high intrinsic activity, and that are highly lipophilic. You get the injection, goes in your brain immediately, starts working very quickly, outcompetes other opioids, etc. These molecules also much more effectively induce these receptor level changes that occur in the midst of opioid tolerance, so internalization, desensitization, G protein decoupling, etc. So that process in of itself, given the receptor level changes that buprenorphine can induce, can make induction onto buprenorphine a little bit more challenging, and can make precipitated withdrawal much more pronounced. So yes, I agree with the fact that it can be more challenging. There are ways around that. And one of the important things when low-dose inducing a patient is to ensure you're meeting their opioid requirements while you're low-dose inducing them onto buprenorphine, right? Which means you're going to have to get comfortable using high doses of full agonists in the background while you're low-dose titrating buprenorphine. Otherwise, they will go into withdrawal. And oftentimes, and I have a protocol that works quite well, other physicians will be like, well, we tried it and our patients went into precipitated withdrawal. And then for me, it's important, it's like, okay, let's dissect what actually happened. And then almost invariably, it becomes clear that, no, this wasn't precipitated withdrawal. They went into withdrawal because of opioid deficiency. You weren't, again, this person could be using upwards of 20,000 mics of fentanyl to meet their opioid requirements. If you're not meeting their opioid requirements while you're low dose inducing, they are going to go into withdrawal, but that's not precipitated withdrawal because of buprenorphine, the molecule. That's withdrawal as a result of opioid deficiency. So that's an important distinction I think we need to make. And the typical accepted definition of precipitated withdrawal is one that I don't particularly agree with. I think it misses some points, and it can make it difficult to distinguish between was this opioid deficiency withdrawal or was this precipitated withdrawal. But the short answer is yes, I do believe that the risk of precipitated withdrawal can be, all things equal, even if you treat aggressively with a full agonist, you're still at a higher risk of precipitated withdrawal in patients who use opioids like fentanyl or fentanyl analogs.
I want to know too, and you've talked a little bit about some of the things that you're kind of looking at in the future here, but what kind of future research questions emerge from this narrative review, and what kind of research studies do you think will be able to address those questions moving ahead?
We need better quality evidence across the board. You know, we're working in a void of evidence right now. All the protocols and guidelines that we have for initiation of MOUD, you know, full agonist, partial agonist, was generated in patients who use heroin, essentially. We're just starting to see the emergence of research in patients who use fentanyl. So those protocols are becoming less and less applicable in the setting of super high opioid tolerance that we're talking about. And when you look at our review, we looked at a number of papers, but the level of evidence wasn't that great. We're not looking at, double-blind controlled, randomized controlled, placebo controls. Right? We're looking at like case use, case reports, etc. Open label studies. So the future is there is this need to generate high-level evidence to know definitively what protocols are superior, which ones work well, which ones are dangerous and should be avoided, etc. The more research we do, the more it's clear that we need higher level of our research and very quickly to be able to make a dent in this overdose crisis.
As we come to the close of our episode, we have a tradition. We like to ask for a little bit of advice. So I'm going to shift gears just a bit here with you, doctor. And I want to ask, you've had this long career in addiction medicine. You've done so much research. You have your approach to different things here. And I want to know, what advice would you offer to the up and coming generation, maybe those that are new to the field of addiction medicine or considering getting involved in the field of addiction medicine? What do you wish you knew when you started, and what advice would you give them on their journey?
That's a good question. Whether it's addiction medicine or any field of medicine, do what fascinates you, do what you love. It's amazing to go to work and not feel as though you're going to work. Right? If you absolutely love what you do and you're genuinely fascinated by it, you're going to come up with these fascinating questions that need to be solved. And you're going to enjoy your work, you're going to enjoy your life. I think everything will be better. So there's a sense of this need for service, serving our patients, but you can serve your patients through any field of medicine. It's all important. Just think about what it's going to look like in 10, 15, 20 years from now when you're still doing this work. The other piece of advice is, medicine typically selects for a certain type of patients, certain type of students. You have to study hard. You're rigid. You study. You get the grades. You do the MCAT. You go to medical school. You memorize the guidelines, and you stay within guidelines. I think that all of that is important, but sometimes we miss the concept of creativity and thinking outside the box and thinking about what else might be possible. And that's where the art of medicine comes in. So what I would say is whenever you encounter a clinical problem, or whenever you treat a patient in a particular way which you feel is not very effective, take a moment to think about what else might be possible. Is there another way of doing it? And then think about what would it look like to study that way of doing things. And I would encourage people to use that approach and consider dedicating some portion of your career to research. Because I feel like the field of medicine in general moves very slowly, but it needs to move. And we need to inject creativity into our clinical practice and clinical research. Otherwise, research just becomes doing research for the sake of doing research, for the sake of publishing and getting grants, as opposed to actually solving clinical problems.
Love it. Amazing advice. Dr. Azar, thank you so much for taking the time to sit down and talk with us today.
Oh, you got it. Anytime. It was fun.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.